This is a reproduction of a talk presented on August 9th, 2019 as part of a day-long meeting in Vancouver, Washington titled Patient-Centered Approach to Chronic Opioid Management, sponsored by the Robert Bree Collaborative. This presentation was recorded at the time, but the audio was poor, so we thought we would reproduce it so people could see what was said. The slides for this talk are in the comments below this video, so feel free to download them. It's a PDF. The title is, What Would Be Good Care? Why can't we make it happen consistently? A frame shift in the questions we ask. Some disclosures. Here, I do not represent views of the United States government or the state of Alabama. I have no pharmaceutical grants, honoraria, contracts, or history of such. I previously owned stock in Abbott and Merck, which were a small percentage of my assets, and it was sold. My wife has the same, as well as some Johnson & Johnson in her private assets that predate our marriage. For the last 17 years, I've been funded by the National Institute on Drug Abuse and the U.S. Department of Veterans Affairs Health Services Research Grant streams, which are focused on homelessness, addiction, and policy implementation research. Let me start with a thesis, but I want to say up front, I believe a systems-level decline in opioid reliance was absolutely necessary given years of extremely heavy and reckless prescribing. Today, I will not be advocating opioids on demand or never tapering opioids. The theses. First, good guidance, such as we may wish to develop now, can go wrong in practice. I will present to you that forced opioid reductions of a non-patient-centered nature are all but mandated at this point, absent any real protection for patients. Scholarly frameworks can help us explain this policy to practice problem and help us understand what we're doing wrong. The second thesis is that I proceed from a theory of patient care that is not just about whether we got the opioids right. The key fundamental is who is the person we're trying to care for. And health systems can misapply guidance by neglecting the fundamentals. I realize in speaking today that there are likely to be a diversity of views in this room, and I'd like to make a request to walk with me. I will profile a discrepancy between good care and what is happening for patients who receive opioids long term. It's not crucial that we agree exactly on the size of that discrepancy. Anyone who knows of my advocacy knows I think it's large. But in principle, none of us want such discrepancies, so let's look at how the discrepancy occurs. Once we can explain what causes actual care to not resemble good care, then we can make better plans going forward. So what would be an idea of good care, at least in relationship to opioids? This is an really shortened version of the CDC guideline, which is over 50 pages, but a few key points emerge. We should reduce our tendency to start opioids as a treatment for chronic pain and offer better approaches. If we're considering opioids as a treatment for chronic pain, we should scrutinize the risks and the benefits carefully and discuss them with our patients. The guideline urges us to exercise caution when escalating doses above 50 or 90 morphine a milligram equivalents. For patients who are already on opioids, it suggests we evaluate harm as seen in that patient and benefits. There's no mandated dose target, and there are no mandated reductions. So what has actually happened? Well, clearly prescriptions have fallen. The chart on the left shows morphine milligram equivalents total from a commercial database. In green, what you see is actually the high dose prescriptions that are over 90 morphine milligram equivalents, and those have fallen the most. That means the biggest reductions have been made in people who typically receive opioids chronically, but there's been reductions across the board, and opioid prescriptions per capita are 19% lower than they were in 2006, the earliest year posted on the CDC website. But something else happened. If you look on the left, you see a story from Fox News, but it's actually an individual, Jay Lawrence, and his wife, Meredith. I had the opportunity to interview Meredith and to review his medical record and write about it with her consent. The story here was that Jay had a very complicated set of pain and other morbidities. He had been on opioids for quite a long time. It was by no means a perfect picture for the benefits of opioids. Nonetheless, there came a point where his doctor said to him, and I'm paraphrasing, "Your quality of life is not worth my losing my license." And he underwent a series of dose reductions. The first one was from 120 to 90, and he and his wife saw on the horizon a month later a dose reduction from 90 to 60, and they decided that the next best step they could take was to purchase a gun and for Jay to shoot himself through the chest with his wife next to him. She was, of course, immediately charged with a crime. I can't remember which one. But that's obviously the kind of story that has drawn some attention. On the right, no death involved, but it's a story written by Terrence McCoy of the Washington Post. He won an award for this, traveling 367 miles with a trucker, Kenyon Stewart, who had been on opioids long term and really could find no one to prescribe for him except this person far away. It was actually a nurse practitioner. And when he reached her, of course, she said, "This is the last time I can write these prescriptions because I can't afford to lose my license." These kinds of events drew public attention, and I'm summarizing many, many events from the late 2018 period. But there was an international stakeholder letter published in Pain Medicine, put together by Beth Darnell, signed by many, including David Yerlink, Robert Kearns, Sean Mackey, and others. Human Rights Watch did a year-long process of reporting on what was happening for pain patients in the United States, dedicating to this the same attention that they would to any other human rights issue. By April of 2019, the Food and Drug Administration issued a formal warning of harm reported from sudden discontinuation of opioid pain medicines. Similarly, the Centers for Disease Control and Prevention issued a formal clarification indicating that they did not anticipate that patients would be cut off suddenly or subject to aggressive or forced tapers as a result of that guideline. The question we have to ask is, how did that all happen? How did it go from an effort to establish what would be better care to address a historic problem of overprescribing to a mess that would require FDA warning, CDC clarification? Was this simply a misunderstanding? Was it a regulatory thing? Perhaps legislatures got too aggressive. Was the situation one where the payers failed to provide help? To some degree, all these things might have played a role, but we actually have formal frameworks that are used by researchers to assess health system and policy changes, and we can use them here, and it can help us prevent this kind of problem going forward. An overarching framework for understanding changes in a health system is called the Consolidated Framework for Implementation Research. You can search it up online. They have an excellent website. For any change that you wish to make in healthcare, one can sort of ask a long series of questions that are broken into essentially 4 pie layers or cake layers here. What's the intervention you want to make? What change do you want to make? What's the outer setting, including the policies and the stakeholders and the people requesting that change? What's the inner setting, which is what's going on inside the organization that wishes to make those changes? Who are the people doing that? What processes are put in place by those people as they attempt to make that change? In the case of what happened with opioids, I'm only going to focus on one of these layers, which is the outer setting, which heavily involves, particularly for opioids, policies. But helpfully, there's actually a framework for analyzing policy scholarship. There's an excellent book published by Paul Kearney, which summarizes roughly 50 years of policy scholarship. And from reading that book, I drew 3 key insights that really speak to the opioid crisis in particular. First of all, policy isn't ever entirely rational. We wish it were so, but it can't be. Leaders often commit to solving problems before they can fully understand them. And quite honestly, we have to understand why that's the case. The average leader in any policy realm has many problems to solve and limited energy to understand all of them. Overwhelming complexity, such as what we can talk about with the opioid crisis, sometimes leads to shortcuts. The second key insight is that policy is not made by one party, but by many. They're typically competing actors and agencies all speaking to the same issue at once, whether it's road safety or water safety or opioids. In fact, with opioids, many agencies are speaking at once, and physicians and patients are absorbing the actions of all of them at once. And finally, and this seems particularly important for the group that is gathered for the BREAK Collaborative, policy monopolies can establish stasis. So a policy monopoly often is a group that might include a government agency such as the FDA, a set of interested parties, for instance, pharmaceutical manufacturers, probably some do-gooders or some activists, and they can establish a fixed understanding of what the problem is that deserves to be paid attention to and whose voices need to be listened to and whose not listened to. And we might say that applied with the aggressive prescribing culture that was put in place in the late 90s through 2012. But those policy monopolies eventually give way. And they can give way in response to events, but very often in response to coalitions of actors who come together to essentially change the discourse, such as really happened with opioids. Who's making policy? Who are the policy actors in the opioid realm? It's really important to understand that, because when you think about the doctors who are seeing patients today, the thing that we are all trained to do as medical students and as graduate residents is to try to understand what are the demands of the environment and how to deliver that. That's actually what makes a pre-med a pre-med. That's sort of why we don't always like them either. It's sort of figure out what everyone wants and try to give it to them. In this realm, I've broken it into 4 quadrants. There's governmental agencies, federal and local, Congress, Health and Human Services, Food and Drug Administration, DEA, and many of these agencies have multiple policies being formed by multiple parts of the agencies. In the lower left-hand side, you see guidances and metrics like the CDC, the Veterans Affairs Department of Defense Guideline, quality metric agencies. In the lower right, I refer to providers and payers like pharmacy chains, pharmacy benefit managers, hospital administration, others. All of these actors are trying to influence that prescription. But finally, because we doctors don't really have time to read all the hundreds and hundreds of documents issued by all of these groups, we take our cues from framing voices, journalists, advocates, government speakers. So if Herman Lopez publishes an article in Vox.com that says doctors gave out opioids like candy, or if we see a book cover that refers to physicians as drug dealers, a person like me says, you know what? I don't want to be that person. I'm just going to try to move along and hope that I get it right. But those framing voices are very influential because there's too many details in the other 3 quadrants. Let me give you just a few examples, and I removed many before giving this talk. The United States Congress passed a law last September, the SUPPORT Act, and many of its provisions concern the treatment of opioid use disorder. But one provision specifies that state Medicaid programs shall have dose restrictions in their opioid medication coverage. They don't say exactly what the limit should be. They don't say how it should be implemented. They don't say if there'll be exception clauses or not. So every state Medicaid office has to now make a decision about how to honor this law. In Alabama, my state, we received a letter saying that starting soon, there would be a 250 morphine milligram equivalent limit per day, and that would gradually decrease all the way to 90. The conditions under which there could be an exception or override are still being discussed. It's not clear how they will be played out. Similarly, the United States Department of Justice speaks. Now, of course, many of us are familiar with prosecutions of pill mills, but here, and this emerged in many communities, the local office in the Atlanta area issued letters to doctors who were identified as higher prescribers than others around them, without much reference to who they were seeing. Essentially, the letter said, you're a high prescriber, and has explained to the media the basic message is, we don't know if you have violated federal law or not, but we just want you to know we're watching. But for the average doctor, the prospect of hard federal time is pretty motivational, and that's a very powerful policy action. Let's move to the lower left-hand quadrant where we talked about guidelines. This is a snippet from a VA Department of Defense guideline. I should say up front, I don't think the guideline itself is considered official VA policy, but it's close to it. This is an algorithm, and it concerns people who are already on opioids. The first question asks us, do the risks outweigh the benefits of continuing opioid therapy? If the risks do outweigh those benefits, proceed to taper. That's a lot like the CDC guideline. There's a set of steps you should do if you decide that the benefits outweigh the risks in the box. And then in that lower hexagon, there's a follow-up question. Is the patient on over 90 morphine milligram equivalents? If so, you can throw out your risk-benefit calculation from higher up and proceed to the taper module. As I said, this is not official VA policy, And moreover, this algorithm in the guideline actually is contradicted by the text of the very same guideline, which doesn't countenance a single question about dose overwhelming that risk-benefit calculation. The contradiction has been pointed out before, it's never been corrected, but for clinicians, they have to decide whether they're going to follow the algorithm on one page or the text on the other on a high-stakes issue like that, and that could be quite confusing. Similarly, many of us have turned to using prescription drug monitoring programs. I'm mandated to check it at least every 6 months for patients on chronic opioids, as well at the time of starting them. But in the month of July, my state issued a warning that appeared every time I opened it up, which is that the department makes no guarantees as to the accuracy, the completeness, or the adequacy of information in the PDMP, and that report should not be included in the medical record. Meanwhile, my employer says that I must include that information in the medical record. Again, a high-stakes communication with conflicting messages from respected agencies. This tends to make doctors scared. In terms of quality metrics, the National Committee for Quality Assurance and other agencies selected a measure to count as unfavorable the number of patients in a practice or an organization who are at over 120 milligram equivalents of opioids. At the time that this was under consideration, the National Committee for Quality Assurance received strong opposition from external parties, including people who had worked on the CDC guideline, and from its own internal consultants. But their concerns were not utilized, and in fact, they embraced and continue to uphold this metric. Think of how a physician can improve their performance on this metric. They can taper the patients very carefully, as we heard about other presentations today, but they can also just decline to see patients or stop their opioids suddenly and also improve their performance. Even if a patient dies from that improves the physician's performance. The last exhibit of many, in short, this is a pharmacy benefit management program insisting that the CDC had recommended that doses be reduced and mandating that that be done for a particular patient. Obviously not at all consistent with the clarification provided by the CDC itself. So those are all the policy actors, and this creates a high-stakes, challenging environment for prescribers. What has been missing? What's been missing is a safe harbor statement for clinicians to know that they can be protected by trustworthy authorities. Similarly, there has not been any institutional review or tracking or accountability related to any harm after opioid stoppage. I might mention a story from a colleague of mine who visited a large set of clinics where they essentially announced to him, he's an opioid expert, we have gotten 125 patients off of opioids. His follow-up question was, how are the patients doing? And the response was, we don't know. They don't come around here anymore. That is a lack of tracking. So when some policy actors at this time are offering conflicting messages, they have mostly transferred liability to frontline doctors and patients, and they rarely offer tangible support to meet the mandates that they set. What are the outcomes of that? A report from the Journal of Substance Abuse Treatment looks at opioid medication discontinuation among Medicaid recipients in Vermont from 2013 to 2017. These were high-dose patients. The median time to discontinuation was a single day. 86% had their doses ended within 21 days. There's no guideline that would approve that pace of taper. 49% had an opioid-related hospitalization or emergency department visit, and 60% already had a substance use disorder diagnosis in the record. Only 1%, actually less than 1%, transitioned to the appropriate medicine for opioid use disorder. And this was in Vermont, which is considered a national leader in getting people into treatment for opioid addiction. So if Vermont's doing less than 1% with these patients, what do we think is happening in the other states? Similarly, this report published in June in JAMA Open Network. In Michigan, 41% of 194 primary clinics surveyed were not willing to schedule an appointment for a new patient who was currently taking opioids for chronic pain. I have to underscore here, no patient can be made safe if no doctor will assume their care. So how should we interpret these very tragic events that drew media attention? You see Jay Lawrence on the left. And there's these others that appear in social media. My son committed suicide 4 months after his docs took him off all pain meds. This is signed by Rick. It's on a public website in a comment section. We'll never get a chance to study Rick or Rick's son because there's no identifiers. No one is tracking this. It just appears. One of our collaborators has identified 300 mentions of suicides on social media. We're not 100% sure. We can't be sure what happened with all of these. There are 85 where a member of my team has linked them to an identifiable person with a death notice. But these really need to be studied in order for us to know what happened. Should we make causal claims about suicides? I suggest we adopt a patient safety framework instead. There are multiple factors that lead to these tragic events that merit study and attention. We don't have to say simply that A caused B. Now, we are normally required in healthcare to track and analyze many safety events. We don't do it here, but we really should. There are over 10 million people on chronic opioids based on a paper published a year ago. That's a lot of people whose care is being changed. We should track what's happening to them. For me, personally, seeing inaction from institutional leadership after safety problems were reported was an inflection point for my work and part of why I write about this. I also wound up with a somewhat different scientific view, which I would like to share, recognizing that many people have taken the view that the optimum path to safety for patients is to reduce their opioid dose if they're on higher doses. And I respect that, but I wonder if that's quite right. So I'd like to talk about clinical evidence. This is why I might be a tad skeptical of a focus on dose reduction as the primary path to patient safety. But I must say, I accept that there is some additional risk, and I rarely have escalated doses in any patient I have on chronic opioids. Reading the literature, I believe that dose is clearly relevant, but is actually overemphasized when we talk about risk of death through overdose. This is a paper published in 2011, a very good paper by Amy Bonner. Dose was associated with a higher risk of death, 7 times higher if the dose was over 100. Age and race, a lower risk of death. If one was young, one had actually a 5 times higher risk than someone who was older. Whites had 3 times higher risk than blacks. We could, if we wanted, act as if every association found in such a study was cause and effect, but I don't think any of us would be comfortable with that. The alternative is to say that maybe all these things that are pulled out of a large database are factors, reflect perhaps some cause and effect, but they're likely factors as important as dose that are visible in the clinic to us who are participating in patient care, but that don't pop out of large databases. Life chaos, financial problems, a return to past alcohol use, resurgence of a medical or psychiatric illness. These are things that we can see in the care of our patients, that we can respond to and care for, but may not be immediately obvious. And some of these things are not measured easily, but may be correlated with dose, race, and age in a particular healthcare setting. And we should try to help them. And that's why I'm not at all want to play down that dose matters or the study in terms of its overall validity, which it is. But merely that we need to think about what it's telling us. Another reason I have focused a little bit less on dose is that a broad theme would be that to save lives, we need to go where the deaths are. This is another analysis of overdose risk by the Bonner team. The red line shows the range of doses that were received by veterans who died of overdose back in the heyday of aggressive and frankly reckless prescribing. The gray line shows the doses received by people who did not die. Clearly, there's some association. Those curves are not the same. But even on that red line, the greater dominance of deaths is at lower than 90 morphine milligram equivalents. To the right of the slide, you'll see me say that at my hospital and many others today, less than 2% of chronic opioid recipients are at over 100 morphine milligram equivalents. There's been a big reduction. We're going to have to take care of the people who are at lower doses and think about what's their safety involved. A report has found that opioid prescribing in the Veterans Administration is down 52%, although opioid overdoses had not changed during that time. That doesn't mean that dose doesn't matter, but it means that we probably need to think hard about who we're trying to protect if so few people are at high dose today. Another way to think about risk and mitigating that risk is to look at other risk factors identified in the literature for overdose, such as aging, medical illness, psychiatric illness, substance use disorders, medication dependence, polypharmacy and social determinants of health. All these things have some basis in the literature as well. So I think it might be better in trying to think about how to protect somebody who may be very challenging to care for and who is on opioids, to ask who is the person we wish to help. What is our model of care for a person with often multiple morbidities? I should disclose to you that that little graph of factors predicting risk of overdose is an adaptation from a larger model produced by my friend Dr. A.J. Manhapra. In fact, he pointed out those factors as relevant to how some individuals who have long-term pain wind up with maladapted, unhealthy behavioral patterns, poor functionality, and poor survival. Some of those things are things we do see in our patients who've been on opioids long-term and who, frankly, were poorly served by them. And the goal in care is to help an individual acquire a new adaptive behavioral pattern, improve functionality, and improve survival. And that's going to involve a lot of work by the patient. But in that larger model, whether or not the reduction of an opioid dose is the key is open to debate. Let me talk about what I do in my practice. I do not have proof or a trial that this makes patients safer. This is the kind of practice we've evolved in our homeless primary care program at the VA in Birmingham. I assess the full history of my patients, including the social history, their exposure to trauma, self-efficacy, and substances. I assess function. What do you do each day? What holds you back? What are your aspirations? Working with the patient, we try to craft a new pain narrative. Instead of simply saying this part of your body causes pain, I discuss the brain's role in generating the pain experience, the way in which receipt of opioids in the past can contribute to that actually, even if there's an experience of relief, and recalibrating the goals of care. I try to introduce a new understanding of the risk of the medications and of their other conditions that they have and how they intersect. Finally, my team and I assess the manageability of the patient's behavior, which can sometimes be challenging. Now, I have to stipulate, I am permitted time to do this because of my special clinic. It takes time to develop trust, and all of this should be compensated work in order to provide these kinds of services. Our opioid-related practices, if stable, I talk about tapering opioids if they're at high dose versus monitoring. And there's a picture of a gentleman who had given his consent and was published in Stat News this year, who was somebody on opioids at high dose. We emphasize behavioral activation, exercise, sleep, social relationships, and social burdens. If we elect to taper, I say we will reverse course if we see harm. I'm aware of no study that suggests that all opioid tapers must be unidirectional. It just hasn't been proven. If the patient's poorly functioning on whatever we're prescribing, the things to consider are intensified monitoring of the patient and leverage, meaning leverage using the prescription to make sure they engage in rehabilitative activity. That is an exercise of power and authority by me as a physician. It could include a switch to buprenorphine even if the patient does not consent. That would often occur if there's very high-risk behaviors, but always an effort to try to find choices the patient can make. Losing authority or these kinds of power plays have their own risks. I do see taper as sometimes helpful and as something that has a risk of adverse outcome, and I have required it, but rarely. My reasoning on opioid taper in particular, any doctor who thinks a patient is harmed has authority to change the treatment, and that includes tapering doses with or without consent of the patient. The physician has that professional authority and decision-making capacity. But that decision entails a risk and potential benefit, both. So far as I see it, we lack prospective evidence that any particular patient is made safer by dose reduction. I'm not saying that doesn't happen. It sure looks like it does. But there is a history of medical reversals that should teach caution. There are a number of treatments where the case for them was rock solid based on observational data, and they were widespread in practice until randomized controlled trials were done. Estrogen for all women after menopause, lidocaine and flecainide after myocardial infarction, pushing the blood sugar lower than 7% for all patients with diabetes. These were all widely accepted and logical until randomized controlled trials proved that these policies, as general practice, actually introduced additional harms. So we need to be cautious about how we think about opioid dose reduction in that case too. My interpretation of the literature is that the overdose event in prescription receiving populations represents a web of risks. Certainly dose is part of that web, but we can make the web of risks worse with taper, particularly if that is carried out in a way that is threatening to the patient, or that is carried out non-expertly or without resources to support the patient. What I think will help, and I'll be closing shortly, any entity urging pain care changes really should track patient-level outcomes, like whether the patients live or die or experience improvement in ability or disability. Ultimately, care that we render is not for an opioid, but for a person with a life history. We can consider both opioid tapering and intensified monitoring as viable in situations where we see risk. We must tangibly support protection of clinical relationships. That includes mentoring and guidance for prescribers. In my hospital, we provide electronic consults, in-person consults, telephone consults. Prescribers need that support. Safe harbors so that the frontline clinicians do not feel completely under the gun. Access to mental and complementary health care and other modalities of care for pain. And I would urge a repudiation of metrics and tools that reward the abandonment of patients. It should not be acceptable for an entity to announce that they've reduced the number of prescriptions or reduced the number of patients on opioids and to have no idea where their patients are. With that, I'll close. I'm very interested in your feedback. I've put up a QR code that will take you to a survey. I would love to, just 6 questions to find out how you received this talk. If you'd like to read more, there are a couple of papers shown in the slides, one with Dr. Adam Gordon and one with Dr. A.J. Manhapra, and I thank you for your attention.